When should you call cancer treatment options and management? Maybe your doctor has helped you coordinate a sizable panel for tumor DNA, like a CDX, 324 gene tumor DNA panel. And maybe your doctor has also put you on a targeted therapy that panel identified, but for some reason you're not responding. Or maybe you started responding for a little while, but now you're not. The implication of that is that you have what is called a desensitizing mutation. You have a mutation that is preventing that treatment from working. It's blocking the uptake of the drug by the cells in your body that it's trying to target. There are two solutions to this potentially. The first, least expensive, fastest one is have cancer treatment options and management review your medical records, have a look at the testing that was already done, and see if perhaps the mutation that is causing the problem, that is the desensitizing mutation, has already been identified, but your doctor just didn't know to look for it or to apply that treatment to you as well. And then we can draft a short document, a white paper, about a 1.5-page document for your doctor to help advocate for you to get on a combination therapy as opposed to just a single agent therapy that isn't working for you because it's missing that desensitizing mutation. Alternatively, when we look at your testing, what we might identify is the test that was used for you was a very small panel, maybe standard pathology 2010 gene panel or something like that. And while your doctor has done an excellent job with the data that they have in getting you on a targeted therapy specific to that data, there's a lot of information that's missing. And we might recommend a more thorough test like a 550 gene tumor DNA panel or a 20,813 gene RNA expression panel, or ideally both. I find that that particular combination of tests usually leads to 8+ treatment options specific to the molecular features of your cancer and a much better outcome for sure. Because when you're dealing with a desensitizing mutation, nothing's going to work. So you have to actually find out what the desensitizing mutation is and get on a drug that targets that kind of binds its hands, stops it from getting in the way. And then the original targeted therapy can work magic. We had a case like this very recently, well, a year ago now, a patient named Gail. She's got her success story on our YouTube channel. Her doctor had done an excellent job for her with the data that he had. He had helped arrange a CDX, which is a decent tumor DNA test, and he had prescribed the top option that the test showed. What he didn't understand when she stopped responding to treatment quite quickly or didn't really respond at all was that he had, unbeknownst to him, the test wasn't as thorough as it needed to be, and this desensitizing mutation had been missed. For Gail, we coordinated the RNA expression 20,813 gene panel, and we found out right away why that treatment wasn't working. She had a particular mutation that was absolutely going to prevent that drug from working, but there was a drug to help target that particular desensitizing mutation. So we advocated with Gail's doctor for her to get on that drug. Within a couple of months, she went from stage 4, get your affairs in order, to complete response from all tumors. Quite exciting stuff. And that was over a year ago, and she's still doing well today. So all that is to say, if you've been put on a targeted therapy, maybe it worked for a little while, but it's not anymore. Maybe it never worked at all, even though it was identified in your testing as supposed to be a fit for you. The reason why, almost certainly, is that there are some desensitizing mutations that need to be targeted simultaneously. Cancer treatment options and management will help you figure out which they are and help you get your doctor on board with a prescription for that so that you can have the best possible outcome.